Okay, so we're talking about community services for self-harm now. And what you'll get over the next kind of 40 minutes or so, I'll give you a bit of general kind of context, which will be familiar to many of you. I'll then talk specifically about the current kind of program, because there's a little bit of confusion about where this bit of work actually fits in with all the many other bits of work that you're all up to. I'll talk about the importance of settings for self-harm services. So, you know, your offer in different settings. Yes, it's not about just the acute hospital setting, community settings, you know, a third sector and voluntary sector colleagues. So settings are really important for self-harm. A little bit about the research evidence and what it tells us about how we should best help people who self-harm. And then lastly, because we're asked about it more or less all the time, is self-harm in the pandemic, and how things are going to evolve in terms of services and the impacts really specifically on self-harm. So let's talk a little bit about context. I'd like to start with a bit of historical context, and it's a bit of an uncomfortable reminder to me that I've been working in this area for 25 years. So for 2.5 kind of decades I've been working in the area, and I actually started with this fellow here, Alan House, former professor of liaison psychiatry over in Leeds, and back 25 years ago things were in a bit of a kind of dire state, I'd say, with respect to self-harm services. Lots of variability. Over the last kind of 25 years, I think there's been a bit of a kind of divergence of opinion about how things have gone. So this was a pair of editorials published in the British Journal of Psychiatry. We've included the links on all the slides, so you can you know, click on them if you want kind of further details. But Alan's view is that things, you know, really haven't got any better in the last 25 years. You know, I think our view, my view, is there's lots of activity in the area of self-harm. We're doing lots more than we did, and things have improved. It's still, there's a long way to go, and that's partly what this program's about. But I think we've come a fair way in terms of progress. And self-harm's never had a kind of higher profile. You know, we've got various reports from, you know, Parliament, from the Royal Colleges, from NICE. You know, we're redoing the NICE self-harm guidelines at the moment, and hopefully they'll come out later in the summer. So lots of activity in the area. I'll talk about this report. It's had a really sorry, my audio's just gone funny. I'm hoping you can still hear me. Can you still hear me, Caroline?
Yeah, it's fine now.
Okay, it's just that I've got a flash up saying my microphone was no longer working.
It was just a second.
Right, okay. So what we're talking about when we talk about self-harm, I mean, it's a lot, you know, all of you all know this, but it's both self-poisoning and self-injury. In hospitals where I tend to work, it tends to be mostly self-poisoning, but in the community, it's mostly self-injury, particularly self-cutting. But it's irrespective of apparent motivation or medical seriousness. So, you know, in the UK, we tend to operate this intent-free definition. We don't often talk about attempted suicide versus non-suicidal self-injury at NICE in research. And the reason for that is that, you know, clinically often it's very difficult to distinguish. There's, you know, people don't fall into these clear groups all the time, and people shift. So motivation shift, intent shifts. And we know that people, you know, even people who are kind of labelled as having non-suicidal self-injury, when you follow them up, are at increased risk of suicide. So we have this kind of intent-free definition. And there's a lot of it about. So it's one of the commonest reasons for hospital admission. 220,000 episodes, over 150,000 people presenting in England every year. So common problem. So it's a common problem. You know, a lot of the workload of liaison psychiatry teams, a lot of the workload of emergency departments, a lot of the workload of community services. But the other thing, of course, is that it's associated with suicide. So this is a paper we published on older people, and older people who self-harmed were about almost 150 times more likely to die by suicide than older people in the general population. This is also a reminder that self-harm can occur anywhere across the lifespan. So sometimes when you talk about self-harm, people think, it's a problem predominantly of the young, and it is more common in young people. The peak ages, late adolescence, early adulthood, in terms of the peak incidence, how common it is, but it can occur at any time. And certainly in older adults, one of the things we're worried about is this link with suicide. And also thinking about, the role of mental health services. Older people in particular, you might think there's a bigger role for mental health services. Only 12% were referred in this study. But I think what we're not saying is management or what helps is the same for everyone, for every age group. So for older people in particular, there are other things you might want to be thinking about: the role of physical illness, bereavement, and social isolation. Probably, formal psychiatric disorder is a bigger factor in older adults who self-harm. So it can occur anywhere across the lifespan, self-harm, and the important thing is the association with suicide. So you've got this common problem leading to potentially very serious outcomes. How do we do in terms of services? So this is that Samaritans report I was telling you about, and the title kind of sums it up really: pushed from pillar to post. So the idea that existing self-harm services can be rather fragmented. This is kind of patient pathway: someone referred into the GP, referred back because they don't quite meet the criteria, not getting access to kind of talking treatments. This idea that services are fragmented, and we need to improve our offer for people who self-harm. And that's really where this current program comes in, to try and improve all of that. So it's actually part of flowing from the NHS long-term plan. It's part of the community mental health kind of transformation, which I'm hoping all of you, very, very familiar with. For those of you who aren't, that's a major investment in mental health services. And really the key bit of that is trying to integrate models of primary and community mental health care. So this idea that there will be, for someone presenting with mental health difficulties, mental health problems, there'll be kind of, if you like, seamless care, and we'll avoid some of that fragmentation that we've already talked about. So it's part of that community transformation work, and specifically this bit of work we're talking about today, what NHS England are asking you to do is think about your plans for how you manage self-harm in the community. So many of you have already got very, very active work streams in this area, and it's really a question of kind of marshalling those together and seeing how they fit. But really that's the ask here. There's been a bit of confusion. Some people have said, well, we've got no funding to do this. I mean, I think the very strong message from NHS England is actually this is part and parcel of the community transformation work. So in terms of resource, in terms of effort, in terms of staffing, it really should be very much part of the community transformation work, the community services work that's well underway across the country. So for you guys, the ask is thinking about what you provide for people who self-harm. What's our role from the point of view of the Centre for Mental Health and Safety, from the point of view of the National Confidential Inquiry? Our main role is the evidence, really. So you're going to hear a bit from me about evidence today. We're also going to comment on any plans. So unlike the first phase of this work, so you're actually in the second phase of the work. There were 10 early implementer sites, and we commented on all their plans. But in this phase, really, we'll comment on the plans if you want us to comment on them. We're more than happy to give you advice, and we'll also advise on measurement. I'll talk about that in a second, and implementation. So important to have a, if you like, a plan for how you're going to implement the changes, as well as saying what changes you might have. How are we going to provide that support? Well, there's events like this, we call them kind of virtual site visits. You'll get email contact from us. There's a website which I'll show you in a second, and really this is an opportunity for shared learning. So there's only two areas here today. Sometimes we have a few more areas on these calls, but we encourage you to steal from each other. So stealing from each other today on the call, but also from the existing sites. And as well as that, Leah has, together with Caroline, organised a series of kind of interactive clinics. That's open to everyone. So everyone in the programme, all areas of the country, where there'll be a theme, generally a kind of guest speaker, and you're welcome to kind of log in and ask questions. So that's if you like our role. Here's the website that I talked about. The links will be included in all the slides, and it's got areas that people might want to look at, the evidence, any kind of relevant policy documents, and do please take a look at that. And if there are any errors, let us know. If there are any omissions, anything you'd like to see on there, do feedback, because that's a continuously evolving resource. I mentioned the importance of measurement. So you'll have a plan, you'll decide what you want to do, but really important that you kind of, if you can, collect outcome data to make sure what you're doing is effective. Obviously, the outcome data that you might want to look at is what happens to self-harm. One of the difficulties there, and if we get a chance, or if you're interested, I know Caroline can talk to this in the discussion, is it's actually really difficult to collect good quality self-harm data, because often self-harm is coded as other things, often it's kind of missed from hospital data collection systems. But there are available data that you can use, which is imperfect. If you're looking at admissions, that tends to underestimate the incidence of self-harm, but there are outcome data you can use. Things like, if you want to measure whether what you're doing is effective, thinking about, have you implemented the nice quality standards for self-harm, getting support from service users themselves, or access to services. So, if you're starting a new service, how many people are going through that service, how many people are accessing that? They're all valid ways of measuring, and measuring is quite important. Now, all of that's going to sound quite overwhelming, plans for self-harm, gosh, it's such a huge area, where do we start? In one sense, you're lucky, because this is the second wave. So you've got all the early implementer sites who have done some of this already, and some of that work's been absolutely kind of terrific, and some of it's summarized on the website in the form of these kind of infographics. So here's one from Frimley, focusing on psychosocial interventions after self-harm, with a 4-session brief psychological interventions, and they've also talked about how they're going to measure impact. Here's one from Somerset, thinking about digital resources. So that's something that's come up again and again and again. Digital resources, how you make sure they're accessible, how you make sure they're useful. So if you like, you've got the early implementer sites to learn from. And this current self-harm work sits with other ongoing bits of self-harm work. So a lot of you will know about CQUIN. So for those of you who don't, targets for health services that attract incentive payments. And we're really pleased that this year, from April, there's going to be a CQUIN on self-harm. Now, what we're trying to push for that with that CQUIN is assessments after self-harm, because we know that not everyone gets an assessment, and it's really thinking about what proportion of assessments by mental health teams are consistent with the NICE guidelines. So what proportion of people who get referred to mental health services, to liaison psychiatry services, get a NICE assessment. That's not the ideal sequence, not the sequence we really wanted, which was what's the proportion of everyone who presents with self-harm who gets an assessment. But I think it was the best we could do. But we can talk a bit more about that. But there will be someone locally will be focused on the CQUIN and how local mental health services meet the CQUIN. So very well worth liaising with those. First, in some areas it's the same person that's on the call today, responsible for the CQUIN, but in other areas it isn't. The other bit of work that you'll all be familiar with is the QI for suicide prevention program that's been going for 4 years now. So quality improvement suicide prevention, funded by NHS England, all 4 waves of the country now covered. And again, we had a similar role supporting with evidence, 3 priority areas: mental health patients, middle-aged men, but also self-harm. So self-harm as part of the National Suicide Prevention Programme, often but not always focuses on hospital settings. But again, as well as, you know, liaising with the CQUIN team, if you're not those people, liaising with the local suicide prevention team, but again, in many cases, you know, it's people within your teams that are helping them. So I think linking in with what's going on already is a key principle. So you're not having to do this from scratch. There'll be lots of activity ongoing at the moment, lots of other programs that you can link in with. The other, you know, key overarching principle really is the importance here of service user involvement. You know, you put that into practice today from people on the call, but that's really important. We know that improves research, but we know it also improves services. And I work across mental health, but actually service user involvement, developing self-harm services is probably the most important of all, because when staff hear from someone that's been through services, that can have often a very, very profound and long-lasting impacts, and often much more effective than me going on about research, hearing from a service user. Okay, so you've had a little bit of the context. Hopefully you're a bit clearer on where this current bit of work sits in relation to everything else. Let's talk a little bit about settings now. A lot of you will have seen me put this slide up before, the Iceberg Model of suicidal behaviour, this idea that, you know, suicidal behaviour is an iceberg with suicide at the top. You've got self-harm presenting to services, and then you've got all this self-harm in the community that's, if you like, under the waterline. And really, for the community self-harm project, we're looking at different levels of the pyramid. So it is people on community mental health team caseloads who traditionally won't have got very much access to psychological interventions, people in crisis who might present through the ED, but also people in primary care, people who don't come to the attention of services. So really, if you're thinking about how you might structure your plans, it's thinking about what you provide across each of the levels of the pyramid, and also thinking about inclusivity and involving groups of people who might either be hard to access or have specific needs, or you know, might have other issues in terms of being given kind of psychological therapy. So, you know, black and minority ethnic groups, older adults, people from LGBTQ plus communities, and also kind of young adults too. Just taking one of those groups, people from ethnic minority groups, this is a bit of work that Caroline was involved in, led by our colleague Bushra Farouk last year. This looked at young people from ethnic minority groups who'd self-harmed. So young people from ethnic minority groups who'd self-harmed in Manchester, comparing them with young people from a white background who had self-harmed in Manchester. And basically, these young people from ethnic minority groups who self-harmed tend to live in more deprived areas than their white counterparts. But the really important thing, I think, is that they were less likely to get an assessment. And everyone's supposed to get an assessment after self-harm. They were less likely to get an assessment and less likely to be referred for mental health care afterwards. So, you know, you've got a big problem here with access, which is, you know, frankly, a little bit of a kind of scandal that we've got people who aren't accessing, don't have the same access to treatments as everyone else. So that's obviously, it's very area dependent. For some areas that we work with, this is this is their main issue. For other areas, you know, it's, you know, one of a number of issues. But, you know, really important thinking about access. The other key area, I think, the other real kind of key opportunity to make a difference, to improve things, is primary care. Self-harm in general practice. Traditionally, you know, we've been weak in the UK about what we do about self-harm in primary care. This is a study we did a few years ago, and it's quite interesting in that this won't surprise you. So this splits people by the deprivation of the area they live in, so how deprived their socioeconomic circumstances. And what you see is people who live in the most deprived areas have the highest rates of self-harm. That's really important. So thinking about deprivation, thinking about equity and access to services. But what was, I think, really striking in this study is this group, the people who lived in the most deprived areas, had the highest rate of self-harm, but they were the least likely to be referred to mental health services. So overall, about 15% were referred to mental health services. But this group in deprivation quintile 5, so the most deprived areas, had the highest rates, but were least likely to be referred to mental health care. So that's an example of what we call the inverse care law, so access to services being kind of least, if you like, in the people who are most at need. What might we do to improve self-harm care in general practice? That's a helpful review done by my colleague Faras Mughal from Kiel. So he talks about facilitators and barriers to effective self-harm prevention in primary care. So training always comes up, communication always comes up, following clinical guidance, involving people always comes up, and the barriers will be very familiar to you. So making sure people have access to assessment, local factors and service provision, referral thresholds, that kind of thing. So encourage you to have a look at that systematic review if you're thinking about what are the kinds of things you might offer in primary care. And a lot of the areas already have thought about how they're going to work with their general practitioners locally. The other thing, of course, are kind of educational settings, and I know for some of you this will be very, very, very familiar. Young people don't just present to their general practitioners by any means. Many of them don't present at all. Sometimes it's families dealing with all this, and there's some helpful resources for families out there, and obviously other times it's schools, it's people in higher education. Now, the current program, the community services program, that's primarily focused on adults, but obviously that's going to be a spectrum, and there'll be synergies with your children's programs as well. But even if we're talking about over 18s, obviously the university setting is an important setting for self-harm and suicide prevention. Involving voluntary sector, third sector, service user organisations, absolutely vital. We're going to hear about an example of self-injury support being involved in, actually providing services. Harmless are involved in actually kind of service provision, providing services. Samaritans are too. Really crucial. I think this isn't something that statutory services can do on their own. We need to involve third sector colleagues, and there needs to be the funding there to enable them to do that. Okay, let's talk. We've talked a little bit about the context. You've heard about the programme. You've heard about the various settings, community settings, educational settings. Let's quickly talk about some of the evidence. Now, in some senses, we're quite lucky if we're talking about some of the evidence. Sometimes you'll hear there's not a lot of evidence around self-harm. In some ways, that's true, but we are lucky enough to have the kind of self-harm guidelines, the NICE self-harm guidelines, which, if you like, summarise the evidence, and in areas where there isn't the evidence, gives you a kind of consensus view on what we should provide. So I think that's a good starting point if we're thinking about what we might provide for self-harm. And of course, the other thing that comes up again and again and again is competencies, is training. What training should we give to our staff? There's lots of different training courses, lots of different training packages, lots of different training providers out there. A couple of years ago, we did this bit of work for Health Education England, where we really mapped out the competencies. So they're the skills, knowledge, attitudes that we'd expect staff to have when dealing with self-harm. There's one for adults, there's one for staff dealing with adults, one for staff dealing with younger people, and one for non-specialist staff. And it really, you can kind of click on the boxes, and it will tell you what generally we'd expect people to kind of know related to that domain. And what we've encouraged people to do is, if you like, either base their training around these, or in many senses people have got, you know, excellent training already in place, but just kind of make sure they audit the training against the competency framework to look for gaps or look for things that might be improved. So that, if you like, is some evidence or some support material for training. Two big things. Well, the first of the big things that actually helps is making sure people get assessed. So Leah's, who's on the call, has done a lot of work in this area too. Just the psychosocial assessment, just assessing people who self-harm reduces the risk of repeat self-harm by about 40%. And that's important because even now we know only about half, maybe just over half of people get an assessment after self-harm, certainly in hospital settings. So making sure people get assessed. What is it about that assessment that helps? Again, this is Leah's work. It's something about the assessment itself, you know, the humanising contact, something that's collaborative, something that's kind of reassuring and compassionate, space and time to talk. So it's something about that interaction between the clinician, feeling listened to, feeling heard, but it's also about plugging people into help. So if you do good quality assessments, you can plug people into the help they need. So, you know, just making sure that people get an assessment, I think, is important. That sounds like a really simple thing, but I think it's really important. But access to psychological aftercare is important too. You know, big data slide. I'm not going to apologise for putting up lots of data, because all I want you to look at is this black diamond here. So what this is a forest plot. It summarises randomised trials for psychological interventions for self-harm. And what this forest plot shows is the CQUIN review led by Keith Wharton, my colleague in Oxford. What it shows is people who get a psychological treatment after self-harm are about 34% less likely to repeat self-harm. Often people say, well, what's the psychological intervention? It's labelled in the CQUIN review as CBT-based psychotherapy. Actually, this is quite a wide variety of different things. So there's, you know, interpersonal therapy here, CBT, problem solving. So, you know, it's about something specifically intended for people who self-harm. You know, providing it is the big issue. Up until recently, no area in the country routinely provided psychological interventions for self-harm. I'm pleased to say that's slowly changing now. In some senses, you know, it's about how you provide it. And the other really important thing about if you're providing a talking treatment is when you provide it. And the bottom line is provide it quickly if you're going to provide it. Get in there quickly. Why do I say that? This is data from the MASH project, the Manchester Self-Harm Project, looking at if people are going to repeat, when do they repeat? And the answer is quickly. So 30% of people who are going to repeat within a year do so within the first month. And what this graph doesn't show is that 10% of people who are going to repeat do so within 5 days of turning up. So this idea that we can, you know, send people an outpatient appointment in a month, or, you know, get them plugged into something online within 3 weeks, that's not really going to cut the mustard. If we're going to intervene for self-harm, we need to get in there quickly. Safety plans, something that has come up again and again and again. Widespread use now, popular. You know, I like them very much. You know, all of you will be familiar with safety plans. So something kind of collaboratively developed with the service user, thinking about warning signs, really thinking about, you know, how they cope, thinking about contingencies, you know, where they might go, what support they might have if they experience another crisis, if they feel like they're self-harming again, thinking about professionals and agencies. Some of them, you know, are online, so online safety plans, they're apps. Others in other areas are kind of written. You know, really good idea. It's interesting though that the evidence isn't, you know, quite as strong as you might think for safety plans. There was this systematic review, again we'll include all the links. Yeah, thought that they were probably good, but it's quite a mixed bag, this. You know, some people with self-harm, the outcomes kind of slightly varied. So, you know, I think the evidence is not hugely strong, certainly in terms of randomized control evidence. You know, another another review also on safety planning interventions. These authors were slightly less positive, saying they're positive studies, but all the studies are a bit different, so it's difficult to kind of generalize a bit. But are they a potentially effective intervention? Yes, they are. Do I personally like them? Yes, I do. But in terms of harder research evidence, there isn't as much as you might think, but a lot of areas are using them. This review is quite interesting because it does point to some of the things that make safety plans a bit more perhaps effective. So making them accessible, making them kind of personalized, involving others, so involving other family members, and making sure it's a kind of collaborative exercise. So it's a bit like kind of assessments. It's a bit like other things in suicide prevention. The what's important, so exactly what domains you record, or exactly what you ask people to do, that's important, but the how of safety plans, I think, is probably just as important, if not more important, than exactly what safety plan you follow. So some pointers there about how, because I know there'll be safety plans being implemented locally. Here are some other resources for how. In fact, Cornwall and Isles of Scilly have been doing some work specifically around safety plans and how they make those more effective. That's the original kind of how-to from the Barbara Stanley and Greg Brown work from the States, and then also some kind of local guides on safety planning. So if you're thinking about strengthening your offer for people in that area, hopefully there's some useful resources. At safety plans, the other thing that comes up again and again, comes up even more now, is the role of digital interventions. Again, it's quite funny in some ways that we as researchers sometimes review the same evidence and come up with kind of different conclusions. So friends and colleagues from Australia thinking digital interventions, yeah, roll them out widely. Other colleagues think, well, actually we need to be a bit more cautious. We need to further understand them. My own view is, yes, they can definitely be effective. Digital delivery can definitely be effective. The principles are the same, but we do need to be cautious. So here's a recent massive study from the States where it was digital interventions, and it was 3 arms: usual care, care management, so online kind of care management where you get assigned a care manager with kind of assertive digital outreach, and skills training. So based on DBT skills training, people were randomized into these huge sample online interventions. What did they find? They found that the interventions didn't have much effect, actually. And one of the reasons for that is that very few people actually took up the offer. So it was online, but it wasn't particularly kind of assertive in a way that face-to-face might have been, and people didn't interact with the offers, so they didn't really take up these interventions, with the result that actually there was no difference from usual care when you're looking at in terms of outcomes, in terms of repetition. In fact, the skills training, it was quite interesting. The skills training was associated with slightly higher risk of future self-harm events. So this idea that digital interventions can't do any harm, can they? Well, maybe they can. So we do need to be cautious. They're not a panacea, but I think they have their place, especially as at times during the last 2 years we've had no choice. We've had to deliver things remotely. So definitely a role, but I think we need to have some caution with point of view of digital interventions. Here's something else we need to have lots of caution about: risk tools and scales. You'll have heard me talk about these. The ubiquitous in mental health, this idea that you can somehow identify people as at high risk. So Leah's work, the work of others as well. What do they tell us? Well, they tell us that risk tools and scales aren't very good. The positive predictive value is about 5%. What does that mean? That means if I rate 100 people as at high risk, the risk tools are right about 5% of the time. In other words, you're wrong 95% of the time. But that isn't the biggest problem. The biggest problem about the whole risk stratification, risk tool thing. It's all the people you rate, or the tools rate as at low and moderate risk, because you exclude those people and you miss people who sadly go on to die in those groups. So it's this idea that risk tools, risk assessment, excludes people. So the idea here is, and it's all in the national guidance, don't use risk tools to predict suicidal behaviour, don't use it to allocate treatment. Just in the last 5 minutes or so, just talk a little bit about COVID-19. Remember, it's difficult to remember back, isn't it? But this is April 2020, seems an awful long time ago. This is what we were all worried about. We were worried about, the indirect effects, mental health effects of COVID being as bad, if not worse, than the direct effects of the virus. What did we learn fairly early on? We learned fairly early on, a study from colleagues in Manchester, that COVID-19 was worsening mental health. So kind of survey methodology, so self-report, all the usual kind of caveats for that. But people's mental health, certainly early on in the pandemic, was about 10% worse than it was before. How did that translate into self-harm? Well, fairly early on, we weren't seeing effects, certainly in terms of presentations to hospitals, certainly in terms of presentations to primary care. So we talked a bit about that. It's early data from colleagues, Sarah Steig and Matthew Carr led this. Actually, this big fall off in attendances for self-harm. This is primary care, national, very big sample. What's that about? That's about perhaps people being told to protect the NHS. It's perhaps about people being frightened. Remember what it was like early on in the pandemic. But also perhaps about accessibility of services, so people hurting themselves, people in distress not being able to access services. But I mean, there is the possibility that like suicide, self-harm fell in the early part of the pandemic. So that this big fall off in help seeking, which I think is the main story there. There is a big fall off in help seeking. This is other data from Greater Manchester, but it's not the same for all age groups. So this is a slightly later study published last year, Sarah Steig again leading it. Just want you to look at the green line. So rates fell kind of in the acute phase for all age groups, but what I think was quite telling is this green group, the 10 to 17-year-olds. We did see a kind of increase in self-harm presentations to primary care. I mean, this only goes up to May 2021, but young people, I think, have been a concern for many of us, particularly from the point of view of self-harm. They've got high rates, but also in terms of their effects on the pandemic. So the bottom line there is a fall in help seeking early on in the pandemic in health service settings. What's happening in community settings? This is data from UCL, and basically it shows that self-harm rates, over the last 2 years in terms of the community setting, according to this study anyway, have remained more or less kind of the same, actually. It's a reminder, this slide, though, that people with mental health problems, mental health diagnosis, have a higher rate of self-harm than people without. But there's not a lot happened in terms of the community rates of self-harm. So what we've got is we had a fall in help seeking to health service settings, no change in community incidence of self-harm. So the question is, are people going elsewhere to seek help? Certainly some of the data we've had from voluntary sector colleagues, helpline colleagues, is yes, that's where people have gone. They've gone online, or they've gone to telephone or text. Here's some data. This isn't UK data, this is international data, which shows that calls to helplines did go up. There's some data from Ireland to suggest that calls to Samaritans increased in length after the pandemic. What's interesting is that quite a lot of this increased call wasn't about suicide, wasn't about self-harm, it was about general worries. But it's a reminder that the importance of the voluntary sector, the importance of the third sector, and the fact that during the pandemic they may have taken up some of the slack from clinical services. Important to monitor this ongoing. So this is Caroline's produced this data, is also on the call. This is emergency department data on self-harm in Manchester. It's slightly kind of crude data because it doesn't include everyone, it misses people. But what we're really looking at here is trends over time. Most striking thing again is this fall off in help seeking in the early part of the pandemic, and then you've got this up and down. You've got kind of possible reductions around second, third lockdown, possible reductions around Omicron. But of course, this also kind of coincides with the end of the year and Christmas as well. So, you know, it's uncertain whether that's kind of pandemic related or just temporal variations, but again, a big fall off. But we do need to monitor the effects of this in an ongoing way. Obviously, some of the longer term effects, long COVID, new variants, etc. But the current, if you like, driver on suicide and self-harm is probably economic, and we know they're some of the most important drivers to increase or decrease suicidal behaviour. So really important that we keep an eye on that, and really important that you keep an eye on that when you're thinking about your plans. So I've told you a little bit about context, the historical context, what a big problem is, how it's linked with suicide, a little bit about a current programme, how it, as part of your community mental health transformation work, should dovetail with QI suicide prevention work, the CQUIN work for self-harm. Talked about, you know, primary care, education, different settings, a little bit about the evidence, especially the importance of assessments and the importance of talking treatments afterwards, and probably not doing kind of risk assessment, which is what we do. A lot of safety plans, I think, be an important part of what you might offer, and then a little bit around self-harm and COVID-19, this fall off in help seeking, but the importance of monitoring things going on. Just want to thank all the people who have worked so hard over the past 2 years back here to you know, carry on producing the evidence and hopefully keeping in touch with you guys.